Dr. Jason King is a Yuit and Wadju Noongar GP, a traditional owner of the land around Perth and north to Duran Bay, Western Australia. On top of his lived experience, Jason has worked in Aboriginal communities in the Kimberleys and far north Queensland for over a decade, with experience in quality improvement systems, health informatics development, and GP supervision. Since 2015, Jason has sat on the NQPHN Clinical Council and previously held an ARCHO position on the Cairns Hospital and Health Services Clinical Council. More recently, he's worked with the Australian Digital Health Agency as a clinical reference lead, advising and engaging with communities and stakeholders on the safe and effective use of health informatics tools such as My Health Record. Since 2018, Jason has taken the beautiful commute to this coastal community of Yarrabah on the land of the Gunjai people, working as the Director of Clinical Services for the Gurani and Yilamuk Health Services. At home, he is a father and a husband to his 3 beautiful children and hard-working wife, Liesl, and enjoys digital art and training in Brazilian Jiu-Jitsu. Thank you. Here's Jason.
First of all, thank you very much for the opportunity to come and talk to you tonight. But before I do start, I'd just like to provide acknowledgement of the country. Kaya Nunakort, Nani Court Jurpin, Nani Court Jurpin, Cadillac Nija, Yobarada Puja, Wankaning Nunakort, Nani Nining Ni, Walang, Kalajining, Nalak, Nungara Kalajin, Walang, Deman Mam, were Ordia Kurakura. I'd like to acknowledge that we are gathered here tonight in the traditional lands and waters of the Yulambara people. I'm happy and my heart is happy to be speaking with you all. Tonight we'll sit and listen and learn about how to improve the health of Aboriginal and Torres Strait Islander people, hopefully. We Aboriginal people were given our knowledge from our ancestors, and tonight I'd like to acknowledge those elders, past, present and emerging, for the strength that they give me to be able to continue in the... Do you want me to walk with that? Is that easier?
I think so. Maybe
away from that
over here.
Hello, excellent. Yes. Maybe a little bit better. Okay. We'll see how we go. Okay. Yeah. So a little bit about myself. Yeah, thank you.
Sorry.
As mentioned, I'm a Yuit Noongar, as well as I have connections to Wadjuk country, which is just an area around Perth. I've been a GP now for over a decade, and I've worked, as mentioned, in many remote communities from Bidjadanga to Beagle Bay to Balgo in the desert country of Western Australia. And I made the move over here in 2015 and started working with Chopper and Health Service in Cairns, where I worked for 3 years at the Edmonton Clinic, which is in the sort of southern corridor of Cairns. 2018, I went across to Yarrabah and I fell in love with that community, and I've been there ever since. I've been very lucky to feel as welcomed as I had there. For those that don't know Yarrabah, it's about an hour's drive southeast of Cairns, so it's around the bay. And like a lot of communities, it's both too close and too far away in many people's minds when it comes to Aboriginal health and when it comes to health in general. But what we have there is a really fantastic community. It's about 4,000 people. They live in about 400 houses. So you can see already, if we start to paint a picture of some of the challenges that we face in a community like Yarrabah, and that's not a rare story at all. A lot of communities that I've worked with and in over the years have shared the same kinds of issues. Where I come from is a little tiny town called Dandaragan, which is about 100 people. It's mostly wheat and sheep farming now. My family have lived there continuously since before 1829, when white people first came to Western Australia. As a member of the stolen generations, my grandmother was inherited before she was taken away a connection to a long history of healers and traditional medicine, which she transmitted to my parents eventually. And after some time before she died, I was able to share a little bit of that knowledge she was able to share with me, but more so, and more importantly, a worldview, or at least an appreciation for health that I think is important to understand when we're looking after our people, for those that aren't Aboriginal or Torres Strait Islander, how to maybe reflect on a different set of values and a set of challenges. Tonight, we're going to be speaking about this 715, which is really sometimes a really contentious subject. We call it the 715, we call it the health assessment, we call it the comprehensive health assessment, or this big long name you can see at the beginning. Probably doesn't really matter what you call it. It's how you do it that matters, I think, at the end of the day, and what your intent behind doing it is. And obviously tonight with PHN, we're trying to look at this from a CQI perspective. I've had the luck of having two careers, one in IT and data systems, and then one in medicine over my lifetime, which has been a fantastic marriage of two different worlds, which gelled together really well. When I add that to working in an Aboriginal community, I can see opportunities for us to do things better by taking a particular respect for community, for families, for spirituality, country, and also this idea that if we examine what we do every day and we look at it from a data perspective, we can actually think about how we might be able to improve on that. This cycle of CQI, which we'll get into a little bit more technically. So just like last night, I went around the tables just to get a sense of where everybody was from, because I've introduced myself. And while there's a lot of you, and I probably won't get to meet you all, I'd love to, just to get a sense of where we're from. So do we have anybody here from the art show sector tonight? Fantastic. Kaya? So Kaya in my language is hello. It's also yes. So we have a word for no, which is yuid, which is actually the word for my particular clan as well. So which is an interesting one. But anybody here from Queensland Health? No. Wow. A couple. Yeah, excellent. And private GPs, practices, mainstream, we say. Yeah, most of you. Doctors in the room tonight. Fantastic. There was a little bit different in Cairns. We only had one doctor up there, and last night we had about the same ratio as tonight. Nurses, great. Health administrators, practice managers, and most importantly, do we?
Last chance.
Last chance. That's a bit dire. Oh, hello. TikTok. Hello.
Yeah, just
Hello.
1 second.
Hello. Is that better? Ah, fantastic. Most importantly, do we have any health workers or health practitioners in the room? Excellent. Welcome. So it's good to know who you're talking to or with tonight, because this is a really varied topic. There's a lot of different avenues we can think about, 715s or health assessments, but also I think a lot of ways you can do them. How do you get your pathway to the goals of tonight, which, if you saw on the flyers, was really about how to do more and how to do them better. I think that, and you know, it's hard to sort of distill what I'm trying to talk to you about tonight into a little sentence like that, because it can feel a little bit transactional. And the 715 has that particular challenge with it, in that in the GP world, it's probably the single highest rebate that we have as GPs, something in the order of $230 or something under Medicare. So there's often and we have to admit this when we see this, and we hear feedback from patients as well about their experiences with the 715 and how the kind of service that they receive, how checkbox it can become, what the requirements are, and how much effort the clinical team who carry this out actually go to make sure that the patient gets what they need. What they need is a really big question, and I'm not going to labour on tonight about Aboriginal and Torres Strait Islander health statistics. I think it's pretty clear most of us should have, I think, a fair understanding of the kinds of barriers, the kinds of statistical problems we see in terms of health outcomes. That is the background of why, part of the background at least, of why we have a thing called the 715, because, or the health assessment, which is obviously largely to help overcome those barriers and also to close the gaps, as we say. With that in mind, we'll just quickly move through a few different slides, which is just an introduction to what it is. So of those people here from private practices, how regularly do you see Aboriginal and Torres Strait Islander patients? How regularly do you carry out 715? Any volunteers to put their hand up and have a chat about that? While you're getting a very delicious and fancy looking entree.
Well, personally, I haven't done it before, to be honest.
Yep.
But at the same time, I'm not really having lots of Indigenous patients. Maybe one patient per 3 months, 4 months randomly.
Okay.
And usually the reason they come to see me is that they couldn't get to their own regular GP.
Yeah, sure. Okay. Yeah. That's interesting, isn't it? We'll talk a little bit about statistics and where Aboriginal and Torres Strait Islander people go for their health as well. So that might be something to think about as well. So, and that's not an uncommon thing we hear is that, you know, people will go to various places to seek health. And as we see at the moment, where, you know, we have workforce shortage in the region with GPs, obviously, access to GPs can be a challenge. And the more remote you go, the more dire that particular situation gets. So that in and of itself provides a bit of a challenge. And for people who might be more mobile, for example, who might live in communities that are spread out or have connections to communities that are more spread out, that during the year they could be in any number of places. And so when the health needs strike or when they have a particular sort of cycle of care that's happening, they might go seek their health providers in different locations. So anybody else here who might have a different experience of carrying out Aboriginal and Torres Strait Islander health assessments? Okay. Those from the Archer sector, obviously, I mean, this is probably bread and butter, I would imagine, for your services, right? Yeah. And that's really what I want to kind of present to you tonight. For the health journey of an Aboriginal and Torres Strait Islander patient in your service, the 715 really is the cornerstone of care for that particular person. That's my proposal to you tonight. That by carrying out a high quality health assessment, you start this cyclical journey for the patient that goes over a lifetime. And each time you flow through that cycle, you learn more and more about that patient and they learn more and more about you. It builds a relationship. So it's not a transactional thing. It's not just ticking boxes and then hitting the submit billing thing at the end. It's about you and the person in front of you. But more than that, it's about that person, their community, their culture, and their lived experience, and how you can use that knowledge that is being shared with you to gain a better understanding about how your health messaging to that person can be taken on board and how they can be empowered through your relationship with them and their relationship with your service to be better able to make the changes in their life that are necessary to improve their health trajectory. So, just some really quick outcomes that we're going to try and hit on. So obviously we're going to try and look at where this came from, which we've kind of touched on already. What are the requirements under Medicare? Because one thing I've learned over the last couple of nights of presenting this in Cairns 2 nights ago and Townsville last night, there is sometimes a lot of uncertainty about what you need to actually do to satisfy the Medicare requirements. What I also would like to propose to you is that that's really just a starting point. Like a lot of things, the bare minimum is often not enough. And Medicare is a slowly evolving machine. And so as we grow our knowledge of what the particular determinants of health might be, those things are slow to be rolled and wrapped up inside what a health assessment could be. And so we're going to touch on a few things that might help you expand how you can conceive of health in a different way and how you might be able to aid a patient and their family and their community. We're going to look at the structure a little bit as well. When I say structure, I'm really talking about clinical structure in terms of logistically, who does what to help you and the patient to go through that journey on the day, but also through that cycle, which goes from year to year, and who your partners in care, or who the team, I should say, around that patient, to think of that as your model of care potentially Now, obviously, I come from the Archer sector, and so I work in the Yarramukka Health Service. We have something in the order of 12 health workers, something like 15 FTE nurses and 7 FTE GPs for a community of 4,000 people. That's quite a lot. And I don't imagine that many services share that, particularly in the private sector, share that kind of structure. That could be challenging to conceive of how you might do this particular model of care. So I'm not going to prescribe to you tonight a particular model that will fit your service, because some clinics are very small. Some are corporate clinics, all have bottom lines which are largely financially based, and we need to recognise those challenges when we're talking about care. The health economics of decision making needs to be taken into account. What I'm actually proposing tonight is actually probably, in terms of this particular health assessment, is on a health economic scale as well, is quite a wise structure as well, because it takes into account scopes of practice and the cost of care to provide a holistic service that rolls across every year as well, and so therefore is of a high quality, and we'll show some links to that as well. Lastly, when we do 715s or do health assessments, as I said, it's not just a fire and forget thing. We don't just do that and then kind of ask a bunch of questions for somebody about their life and their, their history, what the measurements of their blood pressure and their BMI tell us, and then say, oh, thanks very much. Get them to sign their little bit of paper and walk out the door. We're opening a box, a bit like Pandora's box, really, on someone's life and their particular health situation as it stands on the day. It's a snapshot, but it's also a point in time. So when we're finding out these things, you've got to be thinking about what's the next step for you as the clinic, I should say more broadly, for that person, but also what's outside your clinic. So we're really talking about is referral pathways, both internal and external. So we'll touch on those two things tonight as well. If we have time and there's interest, I can describe a little bit more closely the model of care that we do and describe a quick journey for a patient through the clinic. But for the last two nights, actually, it's been more about questions at the end and how you might shape this for your service. So I'm very happy to help answer those questions, whether it's Medicare related or more models of care. So before I move to the next slide, is there any questions for anyone while you're enjoying your, and can you hear me now down the back? Is that actually any better? Yeah, great. Good one. Okay, so this is literally just taken from the MBS website, and there'll be a few of these slides, so don't worry too much about that content. I'm going to speak to them a little bit more than just sort of reading off them. This one we will, though. We'll just kind of touch on what are the basics of who can receive and why. So we talked a bit about this. So we know that there's health discrepancies and disparities. So this is really, as I said, the cornerstone tool for us in health, in the primary care sector, to help address those issues. It's your opportunity to actually start that conversation with the patient to try and find out what might be going on for them and get in early. So it's a very powerful primary health tool. It's available to every Aboriginal and Torres Strait Islander person, no matter what their age. And currently, it's been changed recently. You can claim this every 9 months. The intent isn't to do them every 9 months. The intent is for an annual health assessment. But by having it claimable every 9 months, you actually have the opportunity to recognise things like people moving from place to place, clinicians included. So some places where the clinician might not be there when 12 months comes up the next time. And so it gives you flexibility to make sure that you're able to meet the needs of the person in front of you, not just some annual cycle. So 9 months, it used to be 9 months and 10 days, which is really quite an odd cycle to have now. I think it was even 10 months at one point, but now it's 9 months. So when we're sort of making these points, just have a sort of little think about the systems you have inside your particular clinic around recalls and reminders, for example, and how you might be putting these things into that system and what you might utilise within your tool set to help aid improving how you engage with people to get them back into the service and to be able to have access to this particular point of care. So that leads to that next question of, when we said Aboriginal and Torres Strait Islander people, what does that mean? And this is actually a really common question. So it's really quite straightforward, and it's really not complicated, but it can seem complicated from outside Aboriginal and Torres Strait Islanders culture, actually. So patients who self-identify as Aboriginal and Torres Strait Islander are eligible. There's no onus nor responsibility or requirement for you as a service to take any evidence to prove someone's Aboriginality. It's a self-declaration. Medicare never requires somebody to provide proof of Aboriginality. And so each time I've spoken about this, but also when I do Medicare talks as well, more broadly, people often have this question about identity and how do we as a service, and there's actually a reasonable amount of challenge in people's mindset about what that they need proof. That's not actually the intent behind this. There is a 3-point definition, and who's aware of that from a government's perspective as well, about someone who declares an identity as Aboriginal and Torres Strait Islander. So the 3 points: 1, they have to self-identify. 2, they have to be recognised by the community that they are identifying with, or these days as well, the community the Aboriginal community that they live in. And 3, they have to be able to prove genealogical connection to that particular community. There's no blood tests. We've had that question already the last couple of days to prove that you're Aboriginal. Okay. So that's really straightforward. Again, and this leads into the CQI element of this around patients identifying. And identification can be a challenging and sometimes traumatic point in someone's life for a lot of reasons. For those that might not be aware, this is successive government policies, particularly in Queensland since 1897, when the Aborigines Protection and Opium Management Act was enacted, started this process of managing and controlling Aboriginal populations in Queensland. With that, we know about stolen generation, obviously. People's identities become fractured. Their connection to their communities becomes it becomes challenges to be actually to identify for some people. The intent behind the stolen generation policies was to actually eliminate Aboriginal people from the population, which is really just the key policy definition behind that. And with that, and with societal racism, identifying has been difficult for some people. Acceptance in the broader population has been difficult, and we have a history of racism in this country which underlies that challenge for people. So nowadays, though, there's a change. There's actually been quite a significant shift. The last census, in fact, showed a 25% increase in the amount of people who identified as Aboriginal and Torres Strait Islander people. The ability for people to identify and to discover their links back to those communities and to re-engage with their culture is increasing day by day. And so for some people, they've lived a life full of exposure and experience and connection to their country and their culture. For some, that's not been the case. So there's actually an opportunity for services here, if done correctly, if done sensitively, to actually ask the question of patients. So who do you ask? This is my question to you. Who do you ask if they're Aboriginal or Torres Strait Islander? Everybody. Yes, thank you. Excellent. Everybody who walks through your door. Doesn't matter what the colour of their skin is. Doesn't matter who they've walked in with. Everybody should be asked that question. Throughout this talk, we're going to have a few little CQI pit stops, which is really an opportunity for us to stop and ask these questions, and that sort of leads into that question. The thing that came up last night was not just the billing or the submission of the bill of the 715, but what else you can do alongside a 715, and that can be a little bit complicated. We will touch on that if people are curious about what you can bill. The 715 has the distinction of being the single item number in the MBS of GPs that can be co-claimed with any other item number. No other item number has that distinction. And it recognises the need for opportunistic care. So that can go in two different ways. And we'll talk about some scenarios about how that might pop up in your service and how you might be able to best provide that opportunity to complete the health assessment for a patient, should they come in for some other reason, and you have the time and the patient, most importantly, consents to it. Consent is a core requirement to do a health assessment. Without clear and explicit consent from the patient, you cannot perform it, you cannot bill it. If you bill and I say this very firmly, if you bill a 715 and you haven't got evidence of consent, the PSA and Medicare will audit you and you will be looking to pay back that money. And that there's an increasing attention on that. And I've spoken to Medicare to get their sense of where that's going to go. There has been successive reports over the years about this. And I think it's important to understand that the health sector, the primary care sector, in some avenues, and I think this is probably a minority, and it's that often these problems come from minority practices where predatory billing practices and tick and flicking has become an issue with the 715 because of the lucrativeness of the item. It's, as I said, the most highest paying item on the list. So to be aware of that. The co-claiming is important as well, and there's some very important distinction you need to make around that. Secondarily, there's these peripheral items that come and flow in around the 715. The 10987 number, for example. Very important to know who can provide the clinical activity to be able to claim for that, how it can be claimed, and how the GP and services need to think about the qualifications of their staff to provide this. And I'll provide some distinction around how I feel and how particularly things like the National Aboriginal Community Controlled Health Organisation feel around cultural safety and how it pertains to CQI, for example, but also the performance of health assessments. For those of you that do telehealth, you can perform a telehealth health assessment over video link only, and there's a specific item for that. And obviously that presents some challenges technologically in remote communities, for example, but it may be relevant for some people. And in certain models of care, which can be enabled by particularly health workers and health practitioners who are mobile in the field with certain devices, and encourage you to think about how that might work for you and to stay tuned for future PHN grant opportunities in that regard as well. So this is a little video.
Keeps our health heading in the right direction and can help to stop small health problems becoming big ones. Getting a regular health check tells you important information about the health of your body. Aboriginal and Torres Strait Islander people of all ages can get an annual 715 health check. They are free at Aboriginal medical services and bulk billing clinics. First, you might need to make an appointment. Contact your local health service to find out. They may also be able to help organise transport for you if you need it. When you arrive, you will be asked for your contact details, your Medicare card or your concession card. So make sure to bring them along or check if they are on file.
I'm not going to play the whole thing. That's available. There's a link in the final part of this presentation tonight for those that are interested to follow that and potentially to use when you're looking at engaging with communities and doing health promotion activities, particularly over social media. And we'll talk a bit more about that. Just very quickly, CQI, obviously on a very technical level, there's 4 core reasons that we do CQI. And this is well established, improving population health. And as we've spoken about, this how it pertains to the health assessment is really quite clear. If you do enough of these and you do them well, and you're using evidence-based tools and qualified staff to carry these out in a culturally safe way, you will impact people's health on a large enough scale that we should see population improvement in health. Enhancing the patient experience, and particularly from a cultural safety perspective, I can't stress that enough tonight, that a patient's experience of their health, if it's positive and they feel empowered, will lead to better engagement with their health, better health literacy, better health behaviours. There are sometimes, though, things that we'll talk a bit about in a couple of slides that are a little bit out of the touch or out of the range or the reach of primary care. So having a think about how you might be instrumental in connecting someone to solutions to those problems which sit outside of normal primary care but you will gather the information through a good quality health assessment to become aware of that problem. Like you then hold that baby. It's your responsibility to do something with it. Just like if someone came in with a sore knee and you wanted to, and you did a health assessment and you found out they had a sore knee for the last 3 months, and you can refer them to a physiotherapist for that. Finding out someone lives in an overcrowded house is a piece of information, a core piece of information that will determine largely their health outcomes, overcrowding, for example. So most GPs feel horrified by that prospect because you can't do anything about that, is often what I hear. I can't build another 400 houses in Yarrabah, but what I can do is to help support that person with housing. I can support them by getting things like Healthy Housing Initiative assessments for health, for environmental health assessments. There's a whole host of things which you normally wouldn't sit within our GP training at all, but it's actually part of this, which means we have to be aware of where those particular services lie within your community. Now, this is my first time to Mackay. I'm from Western Australia. I work in Yarrabah. I know very well what works for me and for our community there. You know what's in your community, and if you don't, it really behooves you to look out there and find where those services lie. Provider satisfaction. So doing quality work and getting better at it is something everybody wants to do. We don't qualify as health professionals or run services to run mediocrity. We want to be excellent. And I'm going to put it to you today that to close any gaps, as big as they are, we have to be excellent at our work. We have to aim high and use the best tools at our disposal and apply them in a way that is smart. When we have staff members who are engaged at the top of their scope, they're intellectually engaged, they feel ideologically engaged. And I think one of the aspects we see for people who work more broadly in Aboriginal health is they often have quite a strong ideological drive for social justice. And I think that's an important thing to think about and to try and capture and encourage and empower people to experience. The other thing is, busy work and faffing around. GPs often find that they are burdened with a lot of things, and their time to actually do the things we get excited by, which is to figure out problems and figure out solutions for those problems. And having a team around you that are giving you clinical information at a high level, leveraging all members of the team to be working at the highest capacity that they have. That means empowering your health workers or your nurses in your service to be able to perform health assessments and all the bits within it at a very high level, and to then have a different mindset when it comes to the communication of this information and the synthesis of clinical decision making in a much more circular fashion. So the team can be making decisions and you can understand where the strengths of each one of those parts of your team are. And I speak specifically about Aboriginal health workers and health practitioners in that sense. And where I've learned as a GP, but also coming from a long line of nurses and health workers myself, where that power of the health worker lies. The last one is health economy decision, reducing the cost of care. So again, this kind of flows on off that last one quite well. If people are working at the top of their scope for the majority of their time in the workplace, they're more likely to be doing things that result in much higher output. And so an efficiency perspective, the system runs far more effectively with that in mind. And if you're continually improving that, you'll see cost effectiveness flow. While not traditionally part of CQI technical kind of discussions, cultural safety needs to be considered as part of a CQI practice if the system and the care that you're providing that's attached to that question involves Aboriginal and Torres Strait Islander people. At the beginning, there was a slide, is your health in your hands? And in the Archer sector, we talk about Aboriginal health and Aboriginal hands. And this is really a notion of self-determination, about understanding where answers might be to the questions that we scratch our head about. So this, again, flows again off of those last 2 points about making sure we have an understanding of where we might source the expertise and provide this cultural brokerage that is so important for us to be able to provide high quality Aboriginal and Torres Strait Islander healthcare. So we just quickly went over all this stuff. Now, you mentioned you'd probably see an Aboriginal and Torres Strait Islander patient once every couple of months. It's important to know that Aboriginal and Torres Strait Islander people, 49% seek at least some part of their care in what we call mainstream health. So only 51% of people exclusively seek health in Archer. Now, that means your practices have Aboriginal and Torres Strait Islander people in them every day. And because of the disproportionate nature of health issues, while 49% of 3 to 4% of the population doesn't seem like a big number, the amount of engagement you'll see is actually quite high. I see in Yarrabah, we see our patients to the GP alone 9 times a year on average. That's not the outliers. That's not the very, very complicated. That's just the average. The national average to GPs is something in the order of 3.5 to the GP alone. So you can see the maths will work out in such a way that, you know, you may not be aware, I think, sometimes. And this goes back to that question, which we'll lead on to in the pit stop, who you're looking after sometimes. So if you don't know who you're looking after, you can't possibly provide the care that they need. So this brings us to the first pit stop. Does your clinic regularly check for patient self-identification? Yeah. Nobody's ever said no to this, and everybody understands. And why is that? I think because it's actually a part of your RACGP accreditation. It's one of the requirements of having an accredited practice is to ask that question. It's one of the key elements of I can't remember which standard it is. Forgive me, RACGP gods. The flow on to that is then, do you regularly check your records for patients who haven't identified one way or the other? And what systems do you have in place within your practice to do that check? Does anybody here perform those checks in the room? Got a nod at the back. Can you tell me a little bit about how you would, what happens when you do those checks? You nodded? Sorry, put you on the spot. That's the fun of coming to one of these. Yep, that's right. It's pretty straightforward, isn't it? And what system do you use? Best practice, yeah. So top bar, PenCat, all these tools will help you extract that data quite effectively. And you can then action that through either for a number of means. And as we said earlier in the night, whose job is it to ask that question? And you can think of creative ways to help improve this as well, like signage at your practice. That indicates a few different things, which we'll talk about tonight. One of them is, you know, do you wish to identify? Asking that question of everybody and everybody asking the question. So admin staff, managers, health workers, nurses and doctors, allied health staff asking that question at all times. Now, the asking the question I said earlier is sometimes can be difficult. Some people don't feel comfortable. They're worried about what the answer might be. And on the other side, as I said, there can be some trauma related to this for the individual you're asking. The solution to that question is really cultural safety training done the right way, I think. So lastly, when this kind of flows on what I was just saying, what kind of initiatives do your practices do at the moment to help engage with your community? I mentioned signage, but what else do you guys do to improve this kind of the self-reporting rate? In our service, we regularly get half a dozen to a dozen people every quarter who don't identify as new patients or who haven't identified yet. So even in our context, in a community that is 99% Aboriginal and Torres Strait Islander people by census, we still get people who don't tick those boxes for a variety of reasons. So how do you think you might engage with the community around you? This is part of the feedback we hear from patient satisfaction surveys and I think it's fair to say GP or primary care in the last 40 years has shifted. And one of the reflections we often hear is that GP practices are now less connected to the community around them. It's one of those things we hear quite often from patients and community groups. And that's a challenge because the model of care has shifted and the role of the GP in society certainly has probably changed significantly, even in my short working lifetime. But how could your service look to engage with the community around you? Where might you go to help with that? Does anybody have any thoughts or any examples of what they might do in their services? All right. Something to think about anyway. There often there are community groups, there are elder groups, there are land councils, for example, where you might be able to make contact with them as a service and indicate, even if you're not an AMS or an ARCHO, that you are a safe destination for care if you've gone through the steps to actually satisfy what that actually means. And so there's nothing stopping you from moving outside the boundaries of the clinic to actually take that step and engage with the community proactively. There's a cost associated with it, I get that, but it is actually, it's an important part to help promote your service, to improve people understanding that it is a safe place to be able to receive care. Any questions before we move on? Okay. What's included? As I said, it's a high-paying number, but for a very good reason on a lot of grounds. It evolved out of a series of 70X numbers or 7XX item numbers in the MBS, which were comprehensive health assessments, or CMAs as they used to be called as well. And these were often performed in targeted age brackets. So there was, I think, an over 75s health assessment. There was a CMA provided to people who are residents of aged care facilities. And the 715 evolved out of that, especially one of the later items that evolved. While the others are less prescriptive, the 715 is actually very prescriptive. There's a lot of things you have to do to satisfy doing it. But unfortunately, most practice software doesn't actually make a must-do kind of tick box. There's no red boxes for most of the software that I've worked with to say you have to do these things at different times. Because it's so complicated, it's very hard, and often practitioners feel quite overwhelmed when they see the sheer level of things they have to do. Now, it is quite daunting and probably intimidating if you think about it as a thing you're going to do on one particular day. If you have to sit and do every item on this, first time you meet a patient, it can take a considerable amount of time because it includes information collection, history, examination, investigations, then making an assessment, then making a recommendation, providing that advice back, and then recording all that information. And some of it is sort of gathered from when the nurse or the health worker sees them on the day, perhaps, if they've done blood pressures, heights, weights, etc. But there's a lot of actual talking. There's a lot of yarn that you have to have with a patient to get this information or for them to share it with you. So, and that's, as I said before, is actually just a starting point. As I said, there's a lot to it, but I'm telling you that there's much more you can do as well. If you think of it as a one day and done, you'll never do them because they're just so daunting and such a high level of need. RACGP and NACHO, in fact, have been producing this particular national guide to preventative health for Aboriginal and Torres Strait Islander people for several years now. And as you can see, these are separated by age brackets. This is freely available. You can grab it off the website. And I encourage you to do it. It actually provides a really lovely calendarized view of what you should be doing for Aboriginal and Torres Strait Islander people to provide what they see and what evidence tells you. And there's like all national guides, it's got an evidence chapter in there of what gold standard care is for Aboriginal and Torres Strait Islander people to prevent ill health. And it's sectioned by disease states and all that sort of stuff as well. So it's really easy to follow, but it actually then just further solidifies the fact that preventative health and the health assessment is quite a daunting task if you wish to do it on one particular day. What I'm proposing tonight is that you don't do that because it's very hard. 0 to 15s, lots of stuff. I don't need you to consume this right now. It's just for illustrative purposes. And I know you're not supposed to say, oh, this is a busy slide. That's really bad form for presenting, but it is a very busy slide just to tell you exactly that it's a lot. But as you can probably see, hopefully, some of these things don't need to be asked after you've asked them the first time. In fact, one of the biggest complaints or the biggest challenges we have when we talk to our patients is I have to tell people my story over and over again. And that's frustrating. Every time I go and see someone and they ask me about my family history, it's traumatic. It brings up, and if it's done indelicately, it ignores the potential for recent sorry business, and you're asking about parental health. And you can see where that can lead down to a lot of issues where people shut down. They don't want to talk to you. They feel like you haven't listened to them, or sometimes people haven't even read the record that's there in front of them already. So asking these questions, you can see it builds on itself. You can do them. You don't need to ask some of these questions again. As you go through the age brackets, and this is a super broad age bracket, and you can see where you need to probably think about it a little bit more strategically for adolescents, 15 to 25s, and different parts of it, and the over 55s. Does your software package provide a template that is bracketed by age? Is the next pit stop. Got some nods and some crosses, some shaking of heads. What do you guys use over there, hey? Yeah. Don't have a communicator. Yeah. I quite enjoy using communicator within our particular context. I think it's well suited for that. It's super customizable. Is one of the things. Yeah. Does medical director, sorry to say, does that have age bracketed and sex separated 715s?
Yes.
Yeah. Yeah. Yeah, gotcha. What about best practice? Does it have 0 to 15, 15 to 54, S5 plus?
Changes on the page.
You changed on age. So yeah, that's the question. Yeah, great. All right. Good. So again, thinking about doing more and doing better health assessments. Again, as I said, if you want to do all this at one go, you'll be there forever. And in fact, it's not only fatiguing for you, but can you imagine getting bombarded through all of those questions? If someone who's 50 comes in and you go through all that and then that, and they're probably, maybe they're already unwell, that they've got some kind of chronic disease and they might not feel great as a result of that. How does that feel to be there for probably an hour plus going through this? It's like the worst kind of interview ever. And then you got to hope that somebody does something with that information given to it. So what I suggest is, first of all, thinking strategically about these age brackets. Which part of your service looks after these guys, for example? What kind of events happen throughout the year for your community? And some communities have, say, for example, Children's Day, or they might have, there's an International Indigenous Children's Day, for example, which is a fantastic opportunity to do a targeted rollout of health assessments for your community that you're working in. Movember, another really good example. There's an International Day of Elders as well, I think there's another one. And as well, there's obviously events like, we have one called Sistember, which we have in September for the women of Yarrabah. And for some communities, they get irregular access to mammography, for example. When the pink bus comes, is a good opportunity to wrap that up in that same series of flagship events. So throughout these, you can see that a lot of this is talking about medical history. It's very biomedical. It's a bit of it relates to psychological health as well. But we know in primary care that in Aboriginal and Torres Strait Islander health, over 80% of the presenting problems we have in front of us have a social determinant root cause. So if you're not asking social determinant questions, you're going to miss out on a solution. So community and family safety, early childhood development, education, youth employment, racism, both overt, covert, systemic, institutional racism, housing, environmental and infrastructure access. Some communities don't have similar access to things like transport, They might be relatively close to some things, but to get there might be a trip over a hill, for example, and you've got to have good quality transport to do that regularly. Law and justice, and under the banner of poverty, which is very broad, food security, alcohol and other drugs, and what under this banner of economic participation, which is really not just employment, but underemployment or low-paying employment. So we know, unfortunately, for example, in Yarrabah, the people that are employed in jobs have lower incomes than people from another like-sized community over the hill, such as Proserpine, which is about the same amount of people. So economic participation is a big factor. The key issues we discover, obviously, are things like overcrowding, and that can be very complicated. There's a lot of reasons for that, but there's actually a role in all of this for primary care to start conversations with other service providers. Think about, for each one of these, how does your service engage with the key stakeholders in those areas? What connections can you make to gain access to solutions, but also to help promote your service as well? So in both of those sort of arms of that, there's actually really a strong and powerful way that you can improve the quality of the outcomes of your health assessments. Outside of this, though, but overarching all of it, is this cultural determinants of health. And if you're not thinking about this when you're doing a health assessment, you're going to miss a lot of the things that move between those other spaces, the things that link the social determinant to the biopsychosocial. And actually, this is the slide there is from the picture there is from the MyQU study, which is a national study through ANU looking at participation in cultural experience, cultural activities, working, living and enjoying country, for example. And what it found, there was an initial pilot in the desert country of Western Australia. Those people that engaged with their culture on a daily basis, spoke language and had, it was a part of their everyday life, had far better health outcomes. They had a better reflection of their own health and well-being, and there were specific health markers that were improved. The study's now expanded out to 30,000 people, and initial reports are showing similar data. So people who have a strong culture have stronger lives. Health outcome. Culture is a protective health factor. It's not a burden. It's not a negative. Culture is protective. You don't understand somebody's culture, you can't understand the person. You can't understand their decision-making framework. You can't understand the whys and wherefores, essentially. So connection to country, have a think to those points we said earlier around disconnection. So stolen generations in particular is an important element. So people not knowing and not having access to country. Often we hear this is when you know, oh, someone's BMI is a bit high. And it's quite, you know, registrars, as a supervisor over the years, I've heard this, oh, you know, like they sit in, do you go hunting and, you know, just, you can go hunting and you know, you'll be able to eat back home at least kangaroo, yonga, because it's so low in fat and high in protein. And that's great advice on one level, but that's probably not their country sometimes. It's also, they might not know how to hunt. People's expression and experience of their culture is varied. And it changes over the life course. And without the scaffolding of a strong cultural upbringing, people can feel shame if they don't know that. They can feel traumatized by the fact that you're now talking about things that relate to things like, for instance, you know, the removal of their grandparents, their parents, and even in the current context with child safety removals, the same thing happening again. Kinship systems. So who is around that person to help support them? Who gets to make decisions about someone's life, especially for children and also for our elders? So this is varied. Not everybody is the same. Not every community, not every tribal and clan group is the same. You can assume certain things, but that will often lead you down a path of being awkward and it doesn't help. So asking questions about someone's cultural background is a difficult thing. If you do it indelicately, you can actually do harm. So you need to consider how your service from front to back asks these questions. How do you safely ask these questions? The answer to that question is really, as I said before, high quality cultural safety training provided by people from the community that you work with. It's provided on an online basis by someone in Canberra. It's probably not good for Mackay. It's not good for Yarrabah. So have a look at those and see what you have for your staff if you have something like that. Knowledge and beliefs, and this speaks to not just beliefs of spiritual nature, but also beliefs around medicine. Lived experience of medicine is an important one. Particularly, I think it's important to recognise the role that the health sector has played in the perpetuation of government policy over the years, and why we experience such things as vaccine hesitancy in communities, which is a very different beast to anti-vax rhetoric in sort of northern New South Wales, for example, in say Byron Bay. The rollout in the 60s and 70s of things like Depo-Provera in communities and being sold as vitamin shots to chemically sterilise women in those communities is a living memory for some people. There's documented evidence of this. It was spoken about in the Senate. It's well understood if you work in the field that health has been a traumatising experience to many communities and many people from communities who still live to this day. So if you don't understand people's belief of health and their lived experience, you're unlikely to understand how to best solve that problem. If we approached vaccine rollout and attach vaccine hesitancy the same way we attack anti-vax rhetoric, we wouldn't have gone from 17% single vaccination rate to 80% double vaccination rate in 2 months in Yarrabah. It's a different journey. Language and how you can utilise language in your practice. I have had the privilege of learning my grandmother's language from a very young age, and my children also have the ability to speak language. But still in society, there are problems where people get told not to speak language. My own daughter was told in prep not to speak language because she was speaking garbage. I was very angry about that. I stormed up to the principal's office and said, that's not allowed, you can't do that. And we fixed the problem, but not everybody has the empowerment to do that. But what we found, particularly in Yarrabah, where I work, getting clinicians used to understanding language, and that's not just traditional language. There's Aboriginal English, understanding that it is actually a separate language, understanding that there's other things like Creole and Pidgin and whatnot. So if you don't tune your ear to these things, you're going to miss certain subtleties of communication. Self-determination. The person gets to decide their own health journey. We as doctors and nurses and clinics don't sit in the same position that we might have sat 40, 50 years ago in terms of being the arbiters of clinical decisions. If you want better outcomes, you have to understand that it's a partnership in care, collaboration between you and the patient and the team of people. And cultural expression, as I said, is varied, and you need to be aware of it. Who here has a cultural safety training plan for their practice? Some nods, yeah, great. Do all of the staff do cultural safety training? From admin all the way through to the GPs? Yeah, maybe. Yeah, sure. Yeah. Sorry, you said you're a pharmacist? Welcome. So I didn't ask about pharmacists earlier, I apologise. All right. So everybody should be doing cultural safety training. And as I said, cultural safety training provided by hopefully someone at least nearby your community is a much more powerful and effective source of that information because it contextualizes. It doesn't generalize. Generalization is the problem that we all have. It's assumptions based upon disconnected information. So there are places within every community I've ever worked in that love to be reached out to provide this training. They're waiting to hear from other organisations outside of the normal people who come, like ARCHOs, and outside of Queensland Health, who increasingly are moving away from online tick and flick. health equity reform agenda is very clear in Queensland Health about addressing that issue. I think that's to be commended. It's a big step and probably the first step in Australia to actually combat these issues. So, but the private sector has been slow. We have to admit that, to take up cultural safety training. How often should you do cultural safety training? How often do you do CPR training? You do CPR training every year, right? Do you, so we used to use the term cultural competency, right? And medical people love that because they love to feel competent at things. Competency denotes expertise. Can you be an expert at someone else's culture? Probably not. So we've moved away from the use of the term cultural competency and now we use cultural safety. And there's a very different framework. And I think if people have done cultural competency training in the past, they might still hold on to this. It's just like being updated with the latest medications for diabetes. It's a continuous quality improvement and continuous professional development task that we need to take on board. If you move from one community to the next, do you need to do new cultural safety training? 100%, right? That community is very different. The community of Yarrabah is very different to the community of Cairns, which is very different to the community of Weipa, for example. So each one has its own context, its own history. And though we share one thing, which is colonisation, a lot of other things aren't shared. Some language might be the same. The word where I'm from for hand is mar. The word in Brisbane for hand is also mar. The word for foot where I'm from is jenna. And it's the same around here, I've been told as well. So we share some elements like that, but largely down to our kinship structures, some of our worldviews are very different. So understanding that is important. So cultural safety training is a regular event, even for those that have done it once in the community that live in. Refreshments, because it builds on your ability to relate to the people around you outside of the contact you have with them on a day-to-day basis. That really builds on that second point about community engagement. Who's heard of the term clinical yarning before? Clinical yarning. Anybody? Hands up? No? Yes? A couple. Excellent. That's great. So clinical yarning is a relatively recent movement in medical education to start off with, but also expanding out from that about a different model or a different mode of practice that sits alongside a patient. And medical schools have kind of shifted over the years towards this in various ways without it being so directly connected to a cultural safety approach. But what it does is it actually provides a different way to shape and relate to your patient. And the way we've implemented this in Yarrabah is I tell my GPs, turn off the monitor, turn the chair around, sit down, and imagine you've got a cup of tea in your hand and you're interested in that person in front of you and their story. Truly interested. You're not there to try and mine the problem. You're clever enough to figure that out along the way and to weave it in. But that's a skill that we need to build. And we start with the social yarn. We move then into the diagnostic yarn and then into the management yarn. And there's a link at the end to an online training package for this, which is free. It's easy to access. It's really fantastic. I would encourage all of you to have a look at it. Some of you are going to look at this and say, oh, I already do that. What are you talking about? I'm a good doctor, nurse, etc., etc. I'm a lovely, kind human being. I relate to people. I'm not, you know, and that's great. And it's actually what I found is often that people that work in Aboriginal health are more likely to have elements of this already in their practice, and that's fantastic. It's a skill set though for people who don't grow up in the culture, who don't have the same way of communicating. And I often reflect that it is when my day is filled with lots of yarns, lots of cups of tea, my poor kidneys. But also in that we weave the story and we understand that, you know, at each point there's a different way to bring the messaging across, and that's two-way. So we're not sitting above a patient. How are we going after dinner? Do you have any questions before I get into this last bit? second last bit. Good one. All right. How to be better at them? Obviously, my point to you tonight is probably to think about cultural safety is really the cornerstone of the gateway to a good quality health assessment. Being good at understanding, your software does a lot of work for you, and you can get better at reflecting on that software package and customizing it where possible. You can get better at registering your patients, and you can get better at looking at, recall systems. I say this not cautiously, but I think unless you are culturally safe as a practice, should you be doing 715s for health assessments in the first place? Because I think it's fair to say, if you don't have a good framework to be able to provide safe care and you value cultural safety alongside clinical safety, or if you think of it as part of clinical safety, then doing a health assessment while being culturally unsafe, which is the flip side, has the potential to do harm. We talked about asking the questions, we talked about the history, and then projecting solutions onto somebody without understanding their context can be harmful. At the very least, someone might not do what you've asked them to do. And we hear that story time and time after again. You either don't see the patient again, or they come back and they haven't done what you've told them to do. That in itself belies a mindset which I think is very counter to the notions of cultural safety and working with Aboriginal and Torres Strait Islander people. Or, as I always say, if we treated everybody the way I believe we have to treat Aboriginal and Torres Strait Islander patients, everybody would be better off. That's not saying we treat everybody the same, though. It's the flip side of that. And I think it's an important distinction. Time management. I said in the beginning, if you're going to do this in one day, it's going to take you all day, and you'll do one of these and never want to do them again. If you get a chance to have a look at the way that the information is collected. As I also said, some of this information only needs to be collected once or periodically. The lifespan of the information that you're thinking about needs to be part of your plan on how you're going to roll out, improve the quality and number of these you do. So by doing health assessment checks through the year with a person, as I said, patients come and see us 9 times a year, but they're seeing health workers double that amount throughout the year. Just about every month they're seeing a health worker. Every time a health worker engages with a patient, they're gathering information. Every time a nurse sees a patient, they're gathering information. Every time you see a patient, you can gather pieces of this information. So when the time comes in 9 months' time or a year's time, you've actually done most of the heavy lifting already by having a sense of what is important through that person's lifespan, and using that guideline, the book that I mentioned before, to help improve your understanding of when you should be doing these things means you can plan that out. You can actually start to engage with the patient. Now, I've been talking a bit about health workers here. Who has health workers in their service? Aboriginal health workers or health practitioners? You guys clearly do. Lots of shaking of heads. Now, historically, I think it's fair to say that we have a shortage of health professionals in the region, and health workers are a part of that shortage as well. So they are sometimes hard to find, but we just graduated another dozen in Yarrabah alone last week. These are people who are either looking for a career as a health worker or seeing it as a part of their health career pathway as well to other areas of health. So practices have an important role to play in the employment of Aboriginal and Torres Strait Islander health workers and health practitioners. You need to understand, of course, the differences between the two, because that will tell you a little bit about what they can do for you in terms of clinical duties and what you can claim for. I think there's some parts we'll talk about in a minute. So I'm curious, actually, we asked this question last night. Why don't you have health workers? They are effective first-line clinicians. They provide cultural brokerage for you and the community around you. They're your soft landing and handshake for the Aboriginal and Torres Strait Islander communities around you. I challenge you with that question. Why don't we have Aboriginal and Torres Strait Islander health workers in our in our clinics. It can be difficult when you're running a small business to think about adding another person to your mix. But if 49% of people are coming to private practices for their healthcare, and some of them are going to be there and are going to want to get a health check with you if you're a safe destination, is the heavy lifting to be done by one person in the team, or can you spread that out? Team contributions to health assessments make them flow far more effectively. It broadens the amount of questions and also broadens the perspectives and context of that questions that get asked and the way answers get reported. Often what I'll find is I'll read a health assessment that comes to my desk, and what we often will do is the health worker will come in and say, is there anything that you saw? Well, they might straight up say, oh, look, I didn't put it in the notes just yet because I was worried about this, and they'll bring up something that's totally not amongst all the checkboxes. And that piece of information is gold. It's more important than often a blood pressure or a BMI or a HbA1c. It tells me context, it tells me whys and wherefores. That piece of information is something that, even from my background, I'm not from Yarrabah, I don't know the ins and outs. Your health workers and health practitioners will be able to provide that. They are a powerful part of your arsenal. Same as Aboriginal nurses and Aboriginal doctors as well. So unfortunately, there's only about 450 of us Aboriginal doctors in Australia. So there's not too many of us around. And I think about half of them are GPs. So good luck finding one of us. There's not too many of us, but certainly Katsanam has done a fantastic job over the years at promoting nursing for Aboriginal and Torres Strait Islander people, and in primary care in particular. So having to think about your workforce and how, when you're looking at engaging with communities to provide comprehensive health assessments and care more broadly, employing Aboriginal and Torres Strait Islander people in your practice is a fantastic way to help strengthen your approach. And what I guarantee you will provide you with better quality information at the very least. And part of that cultural safety training is to appreciate that a workforce that is diverse will bring strength. Item numbers. Who here has billed ever a 10987? Yeah. Who here has co-billed a 715 or something else? Right, yeah, okay. Does anybody have any conundrums, any concerns, any fear? There's always a fear of 10987s. Every time I've ever spoken to anyone, they go, I don't know if I'm allowed to do that. What am I allowed to bill for? Because if you read the item number, it's so broad. It's like one of the broadest item numbers that we have in the MBS. It's so vague, would be the best way to put it. The reason it's vague is because it relies on one statement. The statement at the very end of the health assessment. What is the priorities of care for the next 12 months, for this next year, for this patient? Whatever you write in there, if your practice nurse, which can be an EN, a double EN, an RN, an NP, or a midwife, anything they do that aligns with that need can be charged on your behalf as a GP. You don't even need to be on the same planet as the GP for that item to be billed. But you have to be satisfied that they're doing the thing that you've asked them to do and they're qualified to do so. The other person who can do this is an Aboriginal health practitioner who is both registered with APRA and employed in your service as an Aboriginal health practitioner. Who knows the difference between a health worker and a health practitioner? So there's two different certificate levels for those two things, Cert 3 and Cert 4, but you have to be registered with APRA. But in Queensland in particular, there's some challenges because of the award to employ health workers predates the Aboriginal health practitioner being elevated to APRA status, and so they don't figure in the award. So often places that are beholden to the current award in AMSs won't be able to employ people as Aboriginal health practitioners. So places with EBAs and individual contracts and stuff will be able to do that if you employ someone. So there's billable work. Like there are 10 10987s you can do every calendar year, I think it is actually. So these are worth $24, $25, and they can also attract the Medicare Plus item, which is the 75856 where I come from. That's worth another $12. So, for things that could be relatively straightforward. So often you'll see in health checks, someone will say, to monitor someone's risk of cardiovascular disease, I want to monitor their BMI, their blood pressure, their smoking status, their lipids, whether they've got diabetes. So whenever a health worker, a health practitioner goes and takes blood pressure, asks the person about their exercise, he asks them about their smoking status, what are they doing to help fix these issues, and they put that in the notes, they can claim that item. There's no time limit on their engagement either. It's a very weird number for those reasons. It's super broad and it's very easy to get confused by that. But it's actually a super powerful tool because, as I said, this is a cycle of care. You can actually understand those 10 item numbers as being the next 10 months, perhaps, of care that you signpost and engagement with a health practitioner or a nurse or a midwife till the next time they do their health check. And in the gathering of that information, it builds on your next go at the health assessment. So it feeds itself a bit like that snake that bites its own tail. It goes around and around and it feeds on itself. And so you can see that by getting skillful at understanding how to frame that last paragraph of your health assessment, you can actually feed into better quality care through a year instead of kicking the footy down the far end of the park. You pass, you pass, you pass, you pass, you pass, you pass until you get to the far end and you score at the far end. I like footy analogies, sorry. So, does anybody have any questions about that particular item? So the questions that came up last night, these might be sitting in the back of your head. Yes, sorry, far away. Absolutely, yes. Yep. Yep.
Get free dose of administration aids as a compartment to it.
Absolutely. So does anybody know what an HMR is? Yep. So community, non-dispensing community pharmacists who provide HMRs in communities and can also do RMMRs. You can't do a 715 for a resident of an aged care facility, by the way. You have to do a CMIA, which is one of those other times 707 numbers. I think that's the main one for over 20 minutes. But yeah, so you can also do a GP management plan alongside these. You can do, if someone comes in and they've said, oh, I hurt my knee at footy the other day, and you have a look at it and you fiddle around with their knee, you figure it's probably okay, but they probably need to see a physio. If they've come in for that knee reason today, but you've completed everything else for the action of your service to finish off the health assessment, and you say to the patient, hey, look, we can finish off your health check today because we've already done all this work. We've got all this information. It'll take us a little bit of time to sort of go through the rest of it to polish it all up. Then we can do your health assessment. You can then do the 715 alongside a timed item number like a 23 or 36 or whatever. And that's totally fine if the two problems are separate. If they came in for their health assessment and you discovered that they had a sore knee as part of the health assessment, you can't do a 23. Very important to understand that. You can't post hoc separate the issue out from the presenting issue, okay, and then build two things. You'll get busted for that. You have to be it has to be very clear that the person has come in for one thing and you happen to be doing this other thing alongside it, and you can build the two things together. Okay. Same with the 721, 723 or the 732s, like the chronic disease plans. Same as GP mental health treatment plans. If you do a 715 and in that you do a psychological questionnaire, you might do K5, which is a modified validated tool for Aboriginal and Torres Strait Islander populations, which is similar to the K10. And you discover that they have high levels of psychological stress and probably are depressed or anxious or have PTSD or any number of other things. And you found that out within the context of a 715, you can't then, in the same encounter, go and do a GP mental health treatment plan and bill for that. So this is a little complicated and it actually trips people up all the time. What you can do is plan the care out. The good thing is you don't have to slow down your referral to a psychologist because after a 715, there are 5 referable services to allied health you can do. And that includes a psychologist. So you can start the ball rolling then. You can refer to podiatrists, diabetic educators, physios, psychologists, Aboriginal health workers, not just practitioners, but workers as well. So if there's some kind of, if you need someone to go around and do something like spirometry, for example, for a patient, or some other more lengthy assessment that's going to take at least 20 minutes, you can refer to your Aboriginal health worker to go and do that, and they will do an 81300, I think is the item number that they can claim if they're registered, or 81350. Is that right? Something like that. Yeah, it's on the form anyway. When you print it out, it'll tell. Yeah. So, and but the difference is that's a referred thing. It's not just like the 10987, which is kind of just wafty and sits in the middle of nowhere. You have to give a referral reason, a letter. They have to reply just like anybody else. And at the end of it, they have to give you the result, just like any other allied health professional. So it's a really powerful tool. There are 5 of those, and they're very different. They're separate to the 5 you get from your GP manager plan. So you can see you've got this bank of potential referrals you can do. When you are referring, it's important to know where you're referring to. Do you refer someone, often we hear this, is people get referred for a service and they get their referral to them, and then they're told that there's a gap in private land. And for many people, the cost of living at the moment, as I said, economic participation, that barrier is then insurmountable. So that people are not going to do that. So you referred them with a dead end. There's no way that's going to happen. So having a developed set of referral pathways for people who were accepted. So I heard on the first night I did this talk in Cairns that they said, oh, look, I referred someone and they phoned me up and told me I don't accept Aboriginal and Torres Strait Island patients. And I was horrified. That still happens. So that's not a culturally safe referral. If you're sending someone to a place like that, you're putting them in harm's way. And they're not going to get the service anyway. And that's probably reportable, to be honest. The long and the short of it is just like we find in private GP land, and you'll forgive, I last worked in private GP in 2011 in a super clinic, so my experience with that particular part of health is a bit aged, but you build up a bank of people that you trust to refer your patients to. Am I right? Or that would be accurate still? Just like that, you still need to do the same thing when you're referring to people who you would send anyone. You don't want to put them in the hands of someone that you don't trust, or that you think that they're not going to even be able to access. So building up a bank within your service and an awareness of who to refer to and sharing that around with your colleagues is a very important step. We talked a bit about that there. We talked about employment. Thank you very much for your time tonight. I hope you've enjoyed your dinner and you've found this at all useful. I'm happy to take questions, obviously, and also if you have any of this information that I've spoken about tonight is covered under this slide. If you want, there will be a copy that we circulated, so don't worry about taking photos. It's all good. All of this is available to you, so please have a look. The first link is Health InfoNet. So Health InfoNet is a research and statistical clearinghouse for Aboriginal and Torres Strait Islander health. It holds a wealth of information as well as solutions to the problems that it poses in terms of research outcomes. Status indeterminate, so that sort of reinforces identification and the legalities around that. The Clinical Yarning website is a free online training package. I didn't talk tonight about some of the other tools which are evidence-based, so that you could use. So for who does MMSEs for aged patients, so for elderly patients, GPs, right? Yeah, for cognitive decline. So that's a tool that's not actually validated for Aboriginal and Torres Strait Islander patients. It's been actually found to be somewhat inaccurate and provides skewed answers because of educational background, language, culture, etc. The KICO is a Kimberley Indigenous Cognitive Assessment Scale, which is a validated tool for Aboriginal and Torres Strait Islander populations in the north of Australia in both urban and regional and remote contexts. There's a free at the Centre for Healthy Aging, I think it is. You can register with them for free and get access to the full tool to use for your Aboriginal and Torres Strait Islander patients. It's a fantastic way to understand. It has various subtools, which includes a family and kinship report. It has a depression scale specifically for people who might have cognitive decline as well. And all these tools have been scientifically validated for Aboriginal and Torres Strait Islander people. That is a rarity in our field. We don't have a lot of tools at our disposal that have been tested and validated to be effective at measuring this. Memory clinics across the north of Western Australia, NT, North Queensland, all use the kicker as well. So they'll know what you're talking about. When you send them a referral that says, so-and-so is a 75-year-old Gunganji man who lives on country in Yarrabah and has been experiencing cognitive decline and his kicker score is 20, they'll know what you're talking about. So think about that. One of the things I'm talking to people a bit about as well is language and referrals, and talking about cultural language, the MK study, and understanding and asking the questions of someone's cultural heritage and how they identify. I did a talk with the hospital in Cairns at a grand round around clinical language, how we speak about patients. So as I just did then, instead of saying Mr. So-and-so is a 70-year-old Aboriginal man who lives in Yarrabah, where I have that information and have permission to share it, and I've asked permission to do that, my referral letters state the person's tribal identification. That changes the way we receive that information at the hospital and who they then talk about. We don't use the term ATSI anymore. That used to get used in referrals all the time. We stopped doing that. We can change the language. When we change the language, we change the way we reflect on other people. We value their culture and their background. So asking those questions in a sensitive way and getting that information can be part of the way you changed our society, and health in particular interacts and reflects with Aboriginal people. The rest of it is really about the data, which I said I wasn't going to talk about, but it's all there for you to have a look at to inform yourselves. And lastly is the NACHO CQI framework, which kind of goes into a little bit more depth about, particularly from an NACHO perspective, but I think there are some useful lessons to think about how your CQI processes might be improved by including a cultural safety component to how you open up CQI to Aboriginal and Torres Strait Islander perspectives. Thank you very much.